Next, please. And yes, since the 80s year, the beginning of the 80s year, the biomass burning in the Amazon occurs during the dry season. It means 3 to 4 months every year. It's a kind of a pattern during the last 3 decades, but 3-4 decades, but now it's changing. It's increasing this time, this period of dry season, and we call the season of biomass burning or wildfire, as we want to call. However, the human exposure not only occur in the same site of the fire. The fire usually is in the rural area, and the human exposure in the urban area, even in the north region in Brazil. Next. You can see, next please, you can observe this since many years, every year, a huge smoke, a huge thick smoke covering South America. And the direction of this smoke is from east to west in the north, going to the southwest, affecting the population in the big cities as São Paulo, for example. And the barrier is the mountains, the Andes Cordillera or mountains. The direction is affected by this kind of direction because the mountains. Please. And you can observe it here. It's a kind of picture by the airplane. The area is smoke. It is part of the phase of the deforestation. Then the smoke go to the high place, and it is spread to the long distance because the volume of biomass burning, the high temperature, and the wind. Then, in consequence, small city in the Amazon or Middle East of Brazil has bad quality of the air comparing with the big cities and mega cities in the country. Please, next. And here we observe the area of the Brazilian Amazon. The map is showing just the area of the biome Amazon, but we consider the Amazon region or Libau region includes some part of the biome savanna, cerrado, we call in Brazil. It's similar savanna, as well the Pantanal. It's a kind of a wetland. Then the Amazon area is considered 5 million square kilometers. It means 69% of the Brazil area with 28 million inhabitants. Because some people think that there is a few inhabitants in this area, but I'm talking about 28 million inhabitants. They are living usually in small cities because 90% of the 8,500 municipality has less than 5,000 inhabitants. I'm talking about it because it's a problem in terms of methodology for research to evaluate the effects in human health. Next. Then, based on in this kind of rationale of the effects of the air pollution in human health, we carried out many studies. Since 2006, we are in this area, conducted many studies. The first idea was to investigate if the effect of the air pollution was the same or similar what happened in big cities, in mega cities. I can say that yes, it's the same or worse. We study subclinical effect with children in using 3 panel study, following 300 children and school children during 1 semester in 3 different sites. We did many time series studies with hospitalization and mortality. We did a survey of asthma. We investigated the low birth weight, congenital anomalies. Then we proved that it's not good idea to live in this condition with bad quality of air in this area, even in the Amazon, that sometimes people think that population is in the nature, inside the forest, but a big part of the year they are living with inadequate air quality. Next. We show it next, please. We show it also this effect easily using the percentage of our hours per year with bad quality of the air, stratifying in levels of quality of the air. Then we show the increase in terms of hospitalization of children and elderly. What I mean, what I'm trying to say is we have more complex study, more sophisticated study in terms academic, but we have also very simple figure trying to explain to the population what has happened during the dry season, because it's naturalized, I think, for the population that every year during the dry season we have a smoke, and that's it. It means development of the country for one part of the population, one important part of the population in these areas. Next. Then we last years, the recent year, we are living with on a spread of the wildfire in the country, not only in the area that we used to call arc of the deforestation, that is the border of the Amazon, but all around the country. Even though the volume of biomass burning is much higher, much bigger in the Amazon. But nowadays, the quantity of fire, the spot of fire is so huge that not only in Brazil, then the perception, I think, is changing for the population. Next, please. For this reason, we start again as a demand of the Minister of Health, the Brazilian Minister of Health, we start again to do similar things, but try to communicate in a different way. Last year, we did a study using all the area. This red line is the Amazon Brazilian region, not only biome, as I'm saying, including Pantanal, include the savanna area. Then this area, the air pollution, there is a variation in terms of exposure of air pollution. Even when they spot the fire occurs in this part of the Amazon, the smoke do not stay here for a long time as in this green area, because the direction of the wind, we know this. Next, please. Then we showed the pattern year by year where we have the majority of the smoke area, the production of the smoke, the fire. You can see here the seasonality also aggregating 10 years in this study. There is a seasonality when you say Amazon region, it's not burning at the same time in no area. There are differences even inside the Amazon because the difference in seasonality of the climate. Please, next. Then We discussed it also with the health sector, the difficulty to work with only the output or just the data from the health sector as hospitalization by respiratory diseases. If you look at this graph, it's from 2 states, Tocantins and Mato states. You can observe that the high rates of hospitalization by respiratory disease occurs during March, April. That is the end of the rainy season, and it's not during the dry season. There is other factor determining these high rates of hospitalization here. Even if you look during the data of the 5 years, it's the same pattern. The problem in terms of the rate of hospitalization is before the dry season. That is difficult to explain to the health sector that during the dry season, the air pollution is a big problem and a big risk for the population. It's a kind of paradoxes. Next, please. And here you can see we estimated the percentage of day with the bad quality of the air for all this area. It's not Brazil complete, it's just North and Middle East region. Then you can see that this population is living with bad quality of the air, following this new pattern of the WHO, published by WHO, at least for 3 or more months per year. Here we can observe it's the percentage of the days per year during 10 years. Next. And here we can observe the percentage of the population, the absolute number of the population. The average is 2,004 million inhabitants, even with bad quality of the air during 3 or more months per year, every year. Next. We have also result of the estimated of the relative risk using curves of exposure and output. Here is Brasilia, the Brazil capital, just Brasilia. We use in the kind of estimate of the exposure by our AOT. And here, using another kind of exposure, we are calling season. It's a national health information system, but the data is from Copernicus modeling. Then we have more variation in terms of measure for the exposure of PM 2.5. Here we did the same using meta-analysis for all capitals of this northern region and just capitals located in the arc of deforestation. It's more evident the effect. Next, please. And we have also, I cannot show all details because it's not published yet. This kind of estimation by aggregating capitals, because the size of the population, you had to do this, and now we do for all municipalities. Then we estimated the risks for this kind of aggregating of the capital by locating and characteristics of climate. Next, we estimated also attributed fraction for the population. Next, please. Attributed fraction. And we know the number of 1,000 inhabitants affected by this problem. What we are doing, we are going to communicate it easily, and this is for the recent years, communicate easily for the stakeholders, for the population, manager of the health sector and the environment sector. Next, please. I'm finalizing. And our current project, we are estimating the risk and attributed factor for all municipalities to show one by one, estimated the economic costs in terms of using days and the financial cost for the public health system in Brazil. That is huge. And to improve the dissemination of the results by the information using the panel information of the FETP Foundation. We are working in terms of effect of the exposure to the firefighters and brigade of members. Next. And our difficulties in terms of air pollution is the absence or unreasonable coverage of a network of sensors or monitor of the air quality. We are in this area, we are just using the modeling with many difficulties because the characteristics of the territorial characteristics, we are using modeling data with absence of validation. We have difficulty from the health sector to understand this topic, to understand air pollution and all the components. Next. And for the health sector, the difficulties is, I think, for the group, the staff, is to understand the results of the study, to understand the meaning of an ecological, the fallacy ecological, the language, the scientific language that we publish is English, then it's difficult for the health sector to understand risk measures, statistical models. We have to work to this link between scientific publishing and the health sector, and we have to improve the scientific communication. Next. And thank you very much. This picture was taken very close to my house here in Mato Grosso. Teacher.
Thank you so much, Eliane. That was an excellent presentation. I know that you are needing to sign off in a few minutes. We do have a couple of questions for you in the Q&A if you would like to go in and sort of just type your answers to the individuals that have asked questions about your presentation. If you have some time to do that, great. Otherwise, we can try to answer those questions and send out the responses when we send the slides and the recording for this session. So I'm going to go ahead and just introduce our next speaker, Jim Black. So Jim was a clinician in Australia, England, and Mozambique before moving into epidemiology and public health. He's a serial innovator, having computerized the disease surveillance system while working as a provincial epidemiologist in Mozambique, built a new surveillance system while senior epidemiologist in the WHO team in East Timor in late 1999. He co-created the Guidance DS clinical decision support system while working as head in the Victorian Infectious Disease Service, and co-developed the FreeO2 low pressure oxygen storage system while an associate professor in the University of Melbourne's Nosal Institute of Global Health. Lots of great things there, Jim. Since early 2020, he's been working in the state government of Victoria's Department of Health, building the SynServe syndromic surveillance system, which he will present for us today. So I'm going to go ahead and pull up his slides. And thank you so much, Jim, again, for being here and sharing your work with us today.
Thank you. Thanks for this opportunity to show you the work we've been doing in the Department of Health here in Victoria, which is a state in the southeast of Australia. And as we heard in the introduction, we have serious problems with wildfires. And in 2019 in particular, we had a vast area burnt. So that and a number of other reasons has prompted us to have an interest in syndromic surveillance to, as quickly as possible, determine the human health effects of fires that are happening. Next, please. So I want you to imagine this as a kind of stylized timeline from infection or exposure to a toxic hazard in the environment. People take a little bit of time, a variable amount of time before they have any symptoms, and then usually a little bit longer before they seek care from the health service. There may be a relevant diagnostic test at some point further down the track. It then takes some more time to get the test result back, and even more time for an official case to be notified through our normal surveillance system. So next, please. So mostly we get information through a very specific but quite slow notification process, and that's our passive surveillance. The purpose of syndromic surveillance is to try and detect events of public health significance as soon as is possible. Next, please. And the way we've approached that is to try and push the point at which we decide that a person is presenting a syndrome to the very first point where they seek care and their condition is assessed by a trained health professional. In our case, we're using the little bit of text, which we call triage text, which is written at the front desk of the emergency department of a public hospital, and also the small amount of text that is written to describe the patient's condition by nurses attending telephone advice line calls, because that's the first point that we can find as a kind of sweet spot where the patient's condition is assessed by a professional for the first time. Next, please. These are going to come thick and fast, these next, I'm afraid. Now, as we're trying to diagnose the presence of an event of public health significance, we're always weighing up sensitivity and specificity. In other words, we know that we have to trade off the risk of missing some events against the risk of a large number of false alerts. And in other words, we can be wasting people's effort in chasing after non-events, but we're really aiming to reduce the total outbreak size or the total effect of the hazard in the environment. Next, please. So that's the field in which we're working, and we've given our system the very catchy name of SynServe, and SynServe has its own particular paradigm, which is a little bit different to the way many other jurisdictions do theirs. Next, please. So the biggest difference is that we are trying not to just track syndromes and see what's happening, but we're actually finding people who need to take public health action in the real world. For want of a better word, we call them our clients. And together with them, we work out what are the questions that they need answered that might be amenable to an answer from the rapidly acquired data that we get. So we try never to build a module in SynServe that isn't very directly answering a question that will help a decision about public health action in the real world. Next, please. Because it's syndromic surveillance, it has to be very widespread and it has to be very cheap. So we promised ourselves and our collaborators will never change the data that are collected. We won't need to train any health workers. Next, please. Unlike many jurisdictions, because we are only aiming to tell our clients when something bad is happening, we've promised them there will be no long, boring, routine negative reports to put them to sleep every week. Next, please. And importantly, we remind our clients that SynServe itself doesn't take action in the real world. So we encourage our clients to think about what other further information they might have to confirm whether an event is really happening or not. And they'll have other ways to investigate, and that they'll be the ones who take action in the real world. Next, please. So the data sources, and again, please. The data sources are mainly based on these two sources, the emergency department triage text. Again, please. So here's an example of the sort of thing, complete with spelling mistakes, etc., that we get very rapidly within a few minutes, usually, of the patient arriving and being assessed at the emergency room. So, and It's a distinctive language. It mostly uses words from English, but it isn't actually English. And it's a written language rather than a spoken language. So even if I try and read this one out, I need to translate it back to English. This one is saying the patient has 1 day of fever, headache, a dry cough, nausea, and diarrhea on one occasion. The patient returned from travel to China on the 1st of the 8th and presents with a temperature of 38.4, a heart rate of 120, no significant past history. And because the nurse was clearly thinking of avian influenza, the patient's been asked to wear a mask at triage. So you can see that they're very rich piece of information with a lot of detail in them. Next, please. Here's another one that to me suggests that the patient has an exacerbation of asthma, worsening shortness of breath for 2 days, on arrival, heart rate 65, oxygen saturation 92%. Some assessment by the nurse, the patient's not terribly unwell, they're able to speak in full sentences, but they have a past history of asthma and hypertension. Next, please. This is quite a recent one after the COVID vaccines appeared. This one translates as brought in by ambulance with 4-day history of headache and visual changes after receiving the AstraZeneca vaccine 9 days ago. Anxious, says the nurse, and I would be anxious as well, because we'd be worried here about cerebral thrombosis. Next. There's very similar information recorded by the nurses who take the health advice calls. Next, please. And here's another one. This one translates as 2 hours of fever, cough, and blocked nose, has been treated with a drug called Nurofen and another called paracetamol. 30 minutes ago, mildly effective, has a history of COVID vaccination 1 week ago and recent travel to India. Next, please. This one is very useful to us because Melbourne does, the city that I live in does experience thunderstorm asthma events. And they can actually say that sometimes. Thunderstorm asthma wants advice on how often to use their reliever medication. Next, please. Or this one here, 1 week of runny nose, cough. Today, a red itchy rash all over the body, a lump on the neck, swollen glands first noticed 7 hours ago. Negative rapid antigen test for COVID. A palliative cream has been given without any effect, no relevant past history. I've picked a few here just to illustrate how much information is captured in such a small number of words. Next, please. Next. So we have an automated process running in the R statistics package that automatically assigns a presentation or a nurse on call to one of the syndromes that we're interested in 2 ways. The simplest way is to use string matching. Next, please. So, for example, if we search for the string ASTHMA, in other words, the word asthma, we will spot things like this. Short of breath 1 day after a thunderstorm, past medical history of asthma, oxygen saturation 97%, the patient has an audible wheeze. We can assign that pretty easily to the asthma syndrome. Next, please. But there is a limitation with string matching. Here is a driver involved in a 2-car motor vehicle accident, patient reversing out of the car park, struck head on by another vehicle, right at the end, past history of asthma. So it's pretty clear that this is a motor vehicle accident and not asthma, but because the past history has been mentioned, it's also identified by string matching. So this is not ideal, and we much prefer to use the next method. Next, please. Which is a form of artificial intelligence and machine learning called natural language processing. And it uses suitably trained neural networks to assess the whole text rather than just looking at individual words. Next, please. The natural language processing spots things like this: asthmatic in respiratory distress on adrenaline infusion, speaking only words, has gone directly to resuscitation cubicle 3. Next, please. Or this one presents with wheeze and feeling tight, meaning tight in the chest. Onset today with feeling tight in chest, has had relief at these times, 12 puffs, a lot each time. has also had a prednisolone treatment, but is alert. And we find that the natural language processing algorithm is much, much better at automatically assigning the patient's presenting problem to the syndromes that we're interested in. So we've got a number of these, we call them NLP, natural language processing. We have a number of these in place running automatically to assign every single patient who appears in an emergency department or makes a call to the nurse advice line. Next, please. So that allows us to then address particular questions on behalf of our clients. And we've so far developed 4 client question archetypes. And we think that most of the future modules that we add to the system will fit into one of these. Next, please. The first one, and this is unusual for syndromic surveillance, we're sometimes trying to determine if there's a single patient who has a condition of public health significance. And the characteristic for that would be a sick return traveller who's potentially importing an exotic new disease into Australia. And in fact, in this past year, we've seen for the very first time ever, Japanese encephalitis and monkeypox both appearing, and they're modules that we're building now. But we also might want to find a person who's having a severe vaccine side effect. And in each case, trying to identify that person while they're still in the emergency department of the hospital so that investigation can begin as quickly as possible. Next, please. The second one is more characteristic, which is our question is an outbreak happening? Are we seeing an unusual clustering in time and space of one of our syndromes? And we've been building a module particularly for thunderstorm asthma, which can cause hundreds, if not thousands of cases of excess asthma in a single day in our city. Next, please. The one that I actually want to show you today is, it's really addressing a question where we know that there is a release of a hazard into the environment, but we don't, up until now, have a way of assessing what the extent of the human health effects is. And there are 2 areas where we're applying this one. One is what I'm talking about today, the effect of a smoke plume from a fire. And we call wildfires bushfires here, but we also have sometimes factory or warehouse fires that produce toxic fumes, and even occasionally fires in peat beds in the countryside. And the other place that we're applying it is where under Section 22 of a certain piece of legislation, water authorities advise the health department of water contamination events. And then we'll be looking within the distribution zone of that water source, looking for human health effects of that hazard. Next, please. And the fourth one is a much more general one, and it was triggered by the experience of very large thunderstorm asthma events. We have a module which is asking a much simpler question. Does the current patient load, is it increasing rapidly in a way that would put one or more of our hospitals at risk of being overloaded? Next, please. So if we look at an example of the point source hazards smoke module, fortunately, since we began working on this about 1.5 years ago, we haven't had a big fire season yet. And in fact, the La Nina phenomenon in the Pacific usually leads to colder and wetter summers for Australia. But in 2014, there was a bad fire season. Our fire season is mostly January and February each year. And just towards the end of the fire season, a wildfire also caused a fire in an open cut coal mine. And the coal mine continued to burn for several weeks. And there was a plume of toxic smoke from the coal mine spreading across the inhabited areas all around it. And this has been shown in ongoing studies to have caused quite a lot of respiratory illness, amongst other things. Next, please. So the example I'm showing is actually a retrospective analysis, but it is the same thing that we are able to do with our natural language processing for the next fire that comes. And of course, I'm not looking forward to there being any fires. I'm touching wood and doing other superstitious things now in the hope that we won't have any big fires in the coming year. What we're aiming to do is to be able to set up a new module for a new fire in a new location within about an hour. So we have a template process in place with the R analytical script, and we use Power BI, which is the screenshots I'm showing you here, a Microsoft product for the reporting. So we'll set the parameters for a new fire. And then next slide, please. And we will have something up and ready to begin monitoring on the same day that we're notified of the fire. So what we're doing is using postal code areas. And postal codes, everybody in Australia knows their postal code, but they generally don't know many other geographical location markers. Now, postcodes are not ideal because they're irregularly shaped. In some cases, even the centroid of the postcode is not inside the centroid, inside the postcode. The population can be very irregularly distributed, but it is the one piece of geographical information that we've got. So our approach has been to note where the fire is happening, and then mark a radius of 5, 10, 15, 20 to 50 kilometers around that, and determine which postcodes have at least one part of their area inside that radius. So you can see the different, it doesn't really look like a radius, but because of the irregular shapes of our postcodes. But this allows us to look close to and far from the fire and compare it with the rest of the state of Victoria outside a 50-kilometre radius of the fire. And we take that as our baseline for comparison on a daily basis. Next, please. Now, you'll notice there's not a lot of statistical analysis here. We are actually allowing the client to slice and dice the data any way that they like so that they can compare and see whether there is an increase in respiratory illness, either as the count of people presenting to emergency departments or as the rate per 100,000 population, and compare by postal code and see whether there's an increase that seems to be attributed to the fire. We compare a 4-week baseline, that's the map on the left, with the surveillance period, which begins on the day the fire begins. And it's not easy to see in a small screenshot like this, but there is definitely a small increase in the postcodes gathered around the fire in the beginning in the week after the fire began. Next, please. As I said, we allowed the client to then slice and dice the data whichever way they like. So they can choose a specific time period and then look at or choose particular postal codes. And we provide them with the information about the actual rates so that they can drill down and compare. Next, please. You can see this plot is showing the rate per 100,000 population of presentations to the emergency department that have been recognized as respiratory related. And for comparison, I'm just showing 2 plots here. The pink color is the rate for the rest of the state more than 50 kilometers from the site of the fire. And the blue, more jagged line is the rate per 100,000 population for people who live within 5 kilometers of the fire. And we definitely saw during that fire that, although it ran for several weeks, there was a gradual increase in the rate of presentation of people with respiratory illness. And our intention here is to help the public health authorities to decide what kind of alerting to the population is needed, and if necessary, even which part of the population will need to be evacuated. Next, please. Sometimes it's easier to see these comparisons with a weekly rate or a weekly count or a daily. So this is the same information, but as a weekly rate per 100,000 population. And it's even more evident that the people living close to the fire were experiencing more than double the rate of respiratory illness that people living far from the fire were experiencing. Next, please. Sometimes it's easier to see the effect with rates and sometimes with counts. So this is the number of people presenting with respiratory illness. Of course, a comparison with the much larger population of the rest of the state is not very useful. So we're not putting the 50-kilometre comparator here. But again, I think you can see how the baseline 4 weeks before the fire is followed by quite a noticeable increase in the daily count of respiratory presentations. Next, please. And again, it can be easier to see these things in a weekly time bin rather than a daily one. Next, please. And it's very informative to us to look at the distribution by age and sex of the people presenting with the respiratory illness. And you can see here on the left-hand side, the lighter blue color is during the baseline period, the 1 month before the fire began, and in which time there were 115 people presenting within 20 kilometers. And on the right-hand side is the surveillance count in the month following, in which time there were quite a few more people. But even more significant is the way that the children under 5 had the most noticeable increase in presentations. And that seems to fit with what our previous speaker was showing, that young children and elderly people are commonly the ones at greatest risk of respiratory effects from a fire like this. Next, please. This, in fact, is my last slide. And the number of people involved in this sort of work is too many to even just to list names on a slide. There are many, many, and we're very grateful for their assistance. You can contact us on this email address if you'd like more information. Always happy to share our experience. And that's the end.
Wonderful. Thank you so much, Jim. That was an excellent presentation, and it was really interesting to see those plots and to really look at the number of respiratory presentations, both in a 5 and 50-kilometer radius. Just really fascinating to hear. So as a reminder, if you have any questions for Jim, please feel free to place them in the Q&A, and we will get to them after our last presentation. So I am going to go ahead and introduce Alexandra Heaney. She is a lecturer and postdoctoral scholar in the Division of Environmental Health Sciences at the School of Public Health at the University of California, Berkeley. Her research combines epidemiology and computational science to understand the relationships between climate variability and human disease in order to inform how climate change may impact disease risk in the future and how climate information can be utilized to improve early warning disease prediction systems. Dr. Heaney is deeply passionate about teaching and mentoring and is committed to training the next generation of global health leaders to protect human health and well-being from climate change and other environmental hazards. Her current projects aim to identify key hydrometeorological drivers of communicable and non-communicable diseases of global and domestic importance, with a particular focus on waterborne diarrheal disease. And oh my gosh, I'm going to totally butcher the way to say this. So I'm going to go ahead and skip that and let Alex jump in. With collaborators at UCLA and UCSD, Dr. Heaney has also has projects focused on the compound effects of wildfire smoke and extreme heat on respiratory and cardiovascular health. And that is what she will be talking with us about today. So I'm going to go ahead and pull up her slides, and Alex, please feel free to dive in and
Great.
talk about your research that I was not able to pronounce.
No, the scary word you were looking at is coccidioidomycosis.
Thank you.
Which is valley fever fungal infection, not relevant to what we'll be talking about today. So, but thank you so much for that introduction, and I am really happy to be here and to be able to share my work with you all today. So I'm going to be talking about a paper that we just published in the journal GeoHealth And it's about the impacts of wildfire particulate matter emissions on respiratory and cardiovascular health in California. So we'll be sort of geographically shifting a little bit. You can go to the next slide. So this is not something that I need to really emphasize here with this group, I don't think. But we all know that, you know, climate change is resulting in the increased duration and intensity of wildfires. I mean, this is really around the world, but, you know, here we're going to be focusing on the Western United States and California in particular. In 2020, California experienced the worst wildfire season on record, with you know, 9,600 fires and 4.4 million acres burned. And on the right here, you can see a figure from a recent paper by Michael Goss, where he basically, you know, is projecting fire risk into the future under different climate change scenarios. And what we can see, sort of looking from the top plot here, which is a measure of fire risk that is based on historical data, sort of into the future, moving down, that we see fire risk is increasing across a lot of the state here. And then, of course, this sort of increase depends on the climate change scenario that's used. So RCP 4.5, the more sort of moderate emissions scenario, and RCP 8.5, the more extreme emissions scenario. On the right, we can see, you know, just larger risk due to climate change. You can go to the next slide. So we've heard already about some of the health impacts of wildfire smoke. This is a very broad sort of overview, but there really is growing scientific consensus that exposure to wildfire smoke is detrimental for respiratory health. And we'll talk a little bit more about the specifics later on. You can go to the next. There we go. But interestingly, there is a lot of mixed evidence related to the impact of wildfire smoke on cardiovascular health, despite a really strong evidence base of the impact of air pollution generally, or PM 2.5, on cardiovascular health. A lot of the existing epidemiological studies show sort of either mixed results, sort of positive associations, or sometimes negative associations or null associations. So we're not entirely sure sort of what's causing this, and there's definitely more research needed to really figure out what the relationship is between exposure to wildfire smoke and cardiovascular health. Next slide. So the goal of our project was to evaluate the association between fine particulate matter, PM 2.5, that was specifically emitted from wildfires, because there are a lot of different sources of PM 2.5. So we're isolating PM 2.5 from wildfires, and I'll talk soon about sort of how we did that. And the respiratory and cardiovascular hospital visits in California during the 2004 to 2009 wildfire seasons. You can go to the next slide. So how did we do this? So in order to, and this is going to be a very sort of brief description, I'm happy to talk more about this offline, but the way that we isolated wildfire specific PM 2.5, as we call it, is that we used chemical transport model. So this is basically, we used modeling to estimate this PM 2.5 concentration specifically from wildfires. And this model, we used an input of wildfire emissions from the Global Fire Emissions Database. And through running of these models, we can actually isolate the wildfire specific PM 2.5 concentrations. And then we aggregated those to the county level in California, which you'll see a map of soon, from 2004 to 2009. And something that I didn't put in here is that we only focused on the summer months, or the dry season, which also is the wildfire season. Next slide. So here's a figure showing just sort of some aggregated measures of the wildfire PM 2.5 that we estimated. On the left is actually not data that we used, but just to show you a sort of satellite-derived burned areas across the same time span. And we can compare that on the right to this map of wildfire PM2.5. That is the exposure data we ended up using. And this is the average daily PM2.5 in each wildfire PM2.5 in each county across all of the years. So you can see there is definitely spatial variability here. And that it does match pretty well to the satellite-derived measures of wildfires. You can go to the next. So then the next step in our analysis was to define something called a smoke event day. And the way that we did this was by adding the current day wildfire PM2.5 to the previous day. So we have this sort of cumulative effect or cumulative exposure of 1 day lag and current day wildfire PM2.5. And then we said that so we had that for each day. And then we said that a wildfire smoke event day was defined as a day in which that cumulative measure of wildfire PM2.5 was greater than the 98th percentile of all wildfire PM2.5 measures across all days. We did sensitivity analyses where we varied this percentile. For the sake of simplicity in the presentation, I'm going to focus on the 98th percentile, but you can, if you go look at the paper, you can see a lot of those sort of sensitivity analyses. Next slide. So what we can see here is the result of this sort of smoke event day definition. So we see that the average wildfire PM2.5 concentration on a smoke event day is 45.8 micrograms per meters cubed, whereas it's 3.2 on a non-smoke event day. So this is good. We're seeing much higher concentrations of wildfire PM2.5, as we should, on smoke event days, with a pretty big difference between the two. Next slide. And then, as I mentioned, the health data that we used was county level hospital visits. And we had a couple different specific outcomes. We had one that was a measure of all respiratory related hospital visits, and asthma visits, acute respiratory infection visits, COPD, and then all cardiovascular related visits, ischemic heart disease, and heart failure. And as you can see the total sort of number of visits here in this first row. And then we also had these visits broken down by different age groups and by different race ethnicity groups. You can keep next slide. Great. So I'm not going to get into a ton of detail in the statistical analysis here. Again, happy to talk offline about it. But basically what we did was compare the county level daily hospital visit rates on smoke event days and non-smoke event days. And the general method that we used was negative binomial regression models. These models included fixed effects for county, which is basically controlling for any baseline differences that occur in each county. And we also controlled for day of the week, for average daily average temperature for non-wildfire PM2.5. And so this is trying to control for other sources of PM2.5 that might be varying, co-varying with sort of wildfire PM2.5. We looked at rates, so we used a population offset instead of just cases. We looked at, we controlled for the population of the county, and then controlled for seasonality in the data using variables for month and year. So next slide. All right. So getting into some of the results, what we're looking at here is a coefficient plot where the coefficients represent the percent change in the hospital visits, which is on the left here, on smoke event days compared to non-smoke event days. So if we start at the top, we can see that for all respiratory hospital visits, we see a significant positive association. So a 3.3% change in all respiratory disease hospital visits on smoke event days when we compare to non-smoke event days. We see even stronger positive effect for asthma. We see a positive effect for acute respiratory infections, but the confidence intervals cross 0, so this is not a significant effect. And then for COPD, we see a marginally non-significant effect, but the effect estimate is positive. So we are seeing these increases in hospital visits for different types of respiratory diseases in this population associated with smoke event days. Next slide. When we look at the stratification, specifically the age stratification for each of these respiratory outcomes, we can see some interesting findings which actually go along with what we've already been talking about today, which is the sort of takeaway is that older and younger subpopulations are at the highest risk for these respiratory disease outcomes, but that the sort of middle age groups, the 6 to 18, 19 to 64, they also have significant effects for certain outcomes. So for all respiratory, we see this sort of interesting increase in effect as we go up in age, with significant effects being seen from age 6 to 65 plus. In asthma, we see the opposite. We see the highest effects among children aged 0 to 5, with a sort of decreasing effect, but we see significant positive effects across all age groups. Interestingly, acute respiratory infections, which in the full population was not a significant effect, we do see a significant positive effect among children 0 to 5, but not among other age groups. And then COPD, we see that the effect is really concentrated among those older than 65. Next slide. Okay, so now moving on to cardiovascular disease hospital visits, which I mentioned. There is more uncertainty about sort of what the effects are of wildfire PM2.5 on cardiovascular disease. So here, when we look at the sort of full population estimates, we see basically null results. So no significant differences in any of our 3 cardiovascular outcomes on smoke event days compared to non-smoke event days. Next slide. But interestingly, we start to see some significant effects when we look at these different age and race ethnicity strata. So if we look at the top row here, this is our 3 outcomes stratified by different age groups. We see that among the 65 plus age group that we actually are seeing a sort of marginally non-statistically significant effect for all cardiovascular diseases, but that we see actually a significant effect for ischemic heart disease and for heart failure among those older than 65. And then if we go down to the bottom row, we're looking at different race ethnicity groups. We can see that there's actually a significant positive effect for all cardiovascular diseases among the non-Hispanic white subpopulation. Same for ischemic heart disease. And then heart failure, we actually see a positive effect among non-Hispanic whites and non-Hispanic Black subpopulations. So once we start to break down the population into these strata, we start to see actually real results in terms of increase in cardiovascular hospital visits. Next slide. And then this is another finding that, as you can see from the exclamation mark here, I think is very exciting, which we also found a significant interaction between average daily temperature and smoke event days. So what that means is that we saw 1%, specifically, we saw a 1% increase in all cardiovascular disease hospital visits associated with every 5-degree increase on smoke event days. And the reason why I think this is really important, and I'll talk about this in a slide or two, is that, especially in California, we are more and more seeing the concurrence of heat waves and wildfire events. And I think, a direction that, really needs to be explored in terms of the literature, and people are really moving towards this, is thinking about the health effects of these compound extreme events and whether they act synergistically or additively in terms of risk. And, looking at this sort of temperature smoke event day interaction is really just sort of the simplest first step to doing that. But it does show us that, especially for cardiovascular diseases, that this sort of effect of heat and smoke could be particularly dangerous. Next slide. Great. So, this work only included data from 2004 to 2009. And this was, because of basically data availability. It takes a lot of computational power and resources to sort of run these exposure models. So these wildfire PM 2.5 estimates that we get. So we were really only able or had access to 2004 to 2009 estimates. But as we all know, the more recent years have seen more and more extreme wildfire events. And so I think that doing this study and sort of similar studies with much more recent data would really paint probably a more extreme picture and a more current picture of what the health effects are and sort of what the current risk is for respiratory and cardiovascular health due to wildfires in California. Next. So our results, as I mentioned, really confirmed existing knowledge that related to respiratory disease outcomes in the literature, specifically that, we saw significant impacts of smoke on respiratory disease visits, asthma, all respiratory disease visits, asthma visits, COPD, and I can add in acute respiratory infections here if we're looking at young age groups. And relatedly, we saw that the sort of young and the older subpopulations seem to be the most vulnerable to these different outcomes. Next slide. But we did add some interesting findings to the sort of growing literature on the health effects, the cardiovascular health effects of smoke exposure. Specifically that, we saw these positive effects among older populations, which makes sense because, of course, that's sort of the population that these outcomes are almost entirely occurring in, but also in non-Hispanic white and non-Hispanic Black subpopulations. So I think this really indicates that it's important to, if you can, really look at these sort of subgroups and try to untangle where and among whom is the smoke really impacting cardiovascular health, as we may not see it on a population level, but when we look at subpopulations, we can see these effects. Next. And then, as I mentioned, we saw this potential sort of synergistic effect of wildfire PM 2.5 and hotter temperatures on cardiovascular diseases. And you can go to the next slide. And I think that, as I said, this is really interesting and important, and an important next step, hopefully in my work and also others, where the IPCC, the Intergovernmental Panel on Climate Change, in their most recent report, said that many regions are projected to experience an increase in the probability of compounding events with higher global warming, and high confidence in that statement. In particular, concurrent heat waves and droughts are likely to become more frequent. So I think that this is an important thing to think about, and I'm sure will be important sort of across all of these regions. I'd be interested to hear how this applies to the other areas of study that we've been hearing about. Next slide. And of course, I have to thank all of my colleagues, Miriam Marlier, who's at UCLA, Coco Liu, who's now a data analyst at Facebook, Jennifer Stoll at Boston University, who works with Patrick Kinney at Boston University, and Rupa Basu, who is a wonderful epidemiologist and also gave us access to the health data that we use. So thank you so much.
Thank you very much, Dr. Heaney. It's Giovanni Leonardi here. I've been a member of this TEPHINET working group on climate and health, and I've been asked to facilitate the discussion in the Q&A now, as some of the questions that have been raised during the session have already been answered. Thank you to Amber for that. And also, we are missing one of the speakers, so some of the questions may need to continue by correspondence in terms of back and forth with Brazil. But I'd like to perhaps start off with a couple of comments or questions about the other two speakers, if that's okay. One is about Dr. Black. Thank you very much for sharing all that work on syndromic surveillance and your connection with a basic system that is available in many, many countries. And it's wonderful to see you applying that to smoke somehow, and also to apply that to action on the ground, which is really great to see. Now, a question one could ask is, well, you have many choices for how you relate your syndromic kind of data to the wildfires. Or, you know, you call them point sources. You got one fire, but you could have several. So what's your view on what's been done so far by you in Australia and colleagues to link such exposure information? Have you mostly focused on the time relation, or have you also looked at some spatial data? That's a fairly detailed question, I suppose. But any comments on that?
Yes, in fact, we're exploring more methods like an interrupted time series approach, where we'll more formally assess whether there is an increase in the rate of presentations with respiratory illness, comparing the period after the onset of the hazard to the period beforehand. We haven't implemented that in any of our modules yet. But so we're doing the two things. One is to say, are we seeing in that area that's affected an increase after the onset of the hazard, but also using the comparison with the other parts of the state. And it will get complex, because in 2019, for example, there were quite large amounts of smoke that came around the world twice. And there were periods when most of the cities in the east and southeast of Australia had really poor air quality. And it wouldn't make any sense to compare one part of the state to the other, because they were all affected at the same time. But so the reason that we present the data the way we do is that most of our clients, not a great word, but it's the people in our own environmental health unit, for example, are very practice and practical oriented people and not very statistical. So in fact, we're trying really hard not to show them p-values, and especially, I guess this is a lesson for field epidemiology. You have to be prepared to make decisions without the statistics working out as nicely as you would like. And so we deliberately don't show people p-values, and we don't show them too much statistical analysis.
Absolutely, and I think that's really effective. I wonder if anybody would like to comment on that, Dr. Heaney. That my impression is that is definitely worth sharing and encouraging others to do, because it's related to what people can do on the ground. I think the epidemiologists can contribute to this liaison as a general public health function, and not just epidemiology, which is great. I would like to challenge you to also consider that maybe the other level that could be used for is at the level of attribution of any of these to climate change, in the sense that if you have some collection of this work over the years, eventually maybe somebody can look at the time trends and play with how much can this be estimated, quantified over the longer time. But that's a different group of clients, I guess. If you care to comment on that.
No, that's and I find many of these aspects really intellectually interesting and stimulating. And one of the reasons that I've kind of written that paradigm is to keep reminding people like me who can get enthusiastic about the detailed analysis that disease surveillance is for action. And so there are so many things. In fact, as an epidemiologist in the health department, I expect that we'll be passing those data on to people who have a more academic approach. And we have to keep dragging ourselves away from the interesting analyses and saying, no, hang on, it's about advising what to do today, not going into the sort of detail that we could. That I would, if I had my academic hat on, having spent some years in a university, I'd be more enthusiastic about those things.
Oh, well, thank you very much. It's a welcome message, and especially for this audience, nevertheless, it's useful to have your friends in academia who can crack some difficult topics.
Yeah.
And as I don't see other questions, may I ask a comment on your work, Dr. Heaney, just to raise many interesting points in your presentation. And one of them is about the choice of the smoke event day. Is a definition that you came up, which may be useful elsewhere as well. It's really great to see the effort in starting from something like that. And a couple of points. How did you choose that 1 day lag? It's related to an extent to a separate question about the lack of effect on infectious disease endpoints. And I may be confused in my head, because you just compare exposures there when you define, I think, your smoke event day. But because it's known that infectious disease from smoke exposure has a lag of up to 2 weeks, could you comment on the fact I got it all wrong, and the one lag you're talking about is nothing to do with lag between the exposure and the outcome? Please.
Yeah, no, thank you so much. So I will just back up for 1 second and say that, as a sort of representative of the more statistical, academically minded community, when you were presenting your data, I was literally salivating. Like it is the data that we dream about. So yeah, I mean, I think that there's so much potential with this amazing data that you're really doing such a great job of collecting and using and making available. So just wanted to say that yes, I agree.
That's a very important message too for all our audience,
Yeah.
Getting a PhD in environmental epidemiology is welcome, but let's not forget our mission to focus in the field, to the real world, and getting stuff that can help the communities there. So thank you very much for raising that as an academic, Dr. Heaney. Yeah, no, absolutely. And okay, so to the question about the exposure. So we just, to clarify, we only had data looking at respiratory outcomes and cardiovascular outcomes, and they're not the onset of disease. It's when we see the hospital visits. So it's when they show up at the hospital. What we know from previous literature is that the relevant lag times between exposure to really high really high smoke concentrations and most of these sort of respiratory cardiovascular outcomes at a hospital visit measurement tends to be on the order of days. And we actually tested this. So we did, even though I didn't include it in the presentation, we did sort of lagged analyses of up to sort of 3 weeks. And what we saw is that for, almost all, and I would say that the acute respiratory infections, as you're saying,
is sort of the one example where it may have made sense to include a longer lag time. But since we wanted to have the same sort of exposure measurement for all of our health outcomes, for almost all of the outcomes, we saw that the effect was really the highest and was really concentrated on the current day of the really high smoke exposure and the previous day. So that is why we ended up sort of doing that definition. But if you do look at our paper, we include more lags. And so you can sort of see how that effect changes. The reason why we ended up defining this sort of smoke event day, which I know is, it's not a sort of common way of thinking about wildfire events, is that the data that, and this is, to be honest, more of a sort of statistical answer, which is that the exposure data, that PM 2.5 from wildfires, was often very, very low, because of course, if there aren't any wildfires, then we don't have any PM 2.5 from wildfires. And so if we sort of used it as a continuous variable, where we were looking at, the impact on health outcomes sort of per unit, per microgram per meter cube increase in wildfire PM 2.5, we just didn't have enough of a signal, enough variability in that exposure to really be able to measure the health outcomes effectively, or the change in the health outcome. So that's why we decided to sort of group our exposure and to really just look at these really extreme events in order to really get a good sense of sort of what those extreme wildfire events mean for the health outcomes.
Well, that's great. Thank you for the very clear explanation. And there's one more question for you.
Could I throw in one more comment?
Oh, please, go ahead.
About the use of past frequency distributions and percentiles in them. And I liked your presentation. I think that was exactly the right way to do it. But we had an analogous situation where we spent the first couple of months of this project early in 2020 looking at past frequency distributions, daily counts, hourly counts, and so on. And we even had a nice acronym ready to use. It was going to be the Odin score, standing for 1 day in N days, so that we could easily explain it to our clients. Oh, this frequency only occurs once in 500 days.
Yeah.
But then we had lockdowns, we had COVID waves, we had everything else. And the plots of our daily and hourly counts of emergency department presentations literally look like roller coasters for a year and a half. And so one of the common phrases in my team is the past no longer predicts the future. And so for a determined time period that you're analyzing, then it's great. But trying to use frequency distributions from the past to set thresholds for the future has lots of problems in it. And it would have been so nice, but we've just realized for the data we work with, we are now down to 1 month baselines and not trying to use anything more than that.
Yeah.
Great. So the message is keep it flexible and adapt to the change in reality. It's a general point, I think. Well, one of the participants is asking Dr. Heaney, how did you get the data about hospital visits in your city? And would you care to give a brief response to that and encourage others to do similar work?
Yeah, absolutely. So the real answer is through sort of having great colleagues who have access to these data and collaborating with them on this type of work. So specifically for this analysis, Dr. Rupa Basu, who is at the California Environmental Protection Agency, she has, being sort of a government official, has access to these hospital visit data that are, regularly sort of recorded, in the hospitals to the government, but they're only accessible to sort of specific government agencies and groups within those agencies. So I was able to connect with her and say sort of, hey, I'd really like to do this study. She has done a bunch of amazing work. If you want to sort of look at more of this work, she's done a lot of work on heat waves and also more on wildfires and air pollution. So, so we basically sort of joined forces and decided to pursue this. The other thing I'll mention, which is not sort of part of this specific question, but I think is worth throwing in there, is that we also need to always think about sort of the different exposure variables that we're using and make sure we have experts on those in the studies that we do as well, because there are so many specifics and intricacies to, for example, like we've talked about, define what a wildfire event is or what exposure to a wildfire means. There are so many different ways to do that. And so sort of knowing, for example, a modeling, someone who's a modeler who really spends their career and focused on these measurements of what exposure means is also really important for these sorts of projects. So it's what I would say is surround yourself with, great people who are experts in the various parts of your project, and that's usually the best recipe for success.
Thank you very much. That's a very good general hot tip for environmental epidemiology in the field and also at the desk. But I think we haven't got any other questions at the moment, unless perhaps Amandine, as a panel member, you have some general comments you'd like to offer on this session of what's been discussed, the range of field work and really top-notch statistical analysis and epidemiology. How do you see this contributing to the overall effort?
Yeah, I do not have any additional comments, Giovanni, but thank you, to both our panelists. We're very excited to, meet once a month and hear great presentations. So thanks again for joining us today.
Great. Well, I hope that this has sparked your interest. I would like to thank the presenters that have given up their time to prepare and share their work in this way. And I believe there will be some correspondence about making the slides available. Usually we manage to do that. And hopefully a couple of references of the papers written on this. So, and thank you for all participants to have followed this over this early session in the States or lunch session in Europe, and perhaps it's nighttime session somewhere else. And so I'd like to hand over to Amber. So Jim, what time is there? Anyway.
It's approaching 11:30 p.m.
That's it. So thank you very much. Instead of watching TV, thank you very much for joining this. And I'd like to hand over to Amber for the final words.
Thanks, Giovanni. And I just want to echo your thanks to Jim and Alex for joining us today, and also for Eliane, who needed to jump off early. It's truly been eye-opening and a great discussion, and we really appreciate you all taking the time to share your experience and expertise. We are going to go ahead and share the recording and the slides with all of the attendees who are here. I know that a few people asked that question in the chat. And as you may or may not be aware, this is part of a monthly series. So each month we are covering a different topic related to climate change and health. So I encourage you to please join us next month on Wednesday, August 24th, where we will be talking about hurricanes and cyclones. And we're going to have some presenters from the Mozambique Field Epidemiology Training Program, as well as some possible speakers from Bangladesh and India. Just keep an eye out on TEPHINET's social media channels, EONFI, and the Global Consortium for Climate and Health Education will be sharing those registration links shortly. So thanks everyone for joining us today, and I hope that you have a good rest of your morning, afternoon, or evening from wherever you're joining us from. Take care.
Thank you.
Thanks, everybody.
Thank you.